easy fatigability for 9 months, and recurrent jaundice for 9 months. So, history of present illness. Patient having fatigability for 9 months, which is insidious onset and which is causing limitation of her strenuous physical activity. Otherwise, patient is fully ambulatory. There is history of recurrent jaundice since 9 months. In between, the patient have two episodes of jaundice. First episode was 9 months back, which was insidious in onset, progressive, painless, associated with high colored urine, and which resolved within 35 to 40 days without any intervention. Patient developed second episode of jaundice for last 2.5 months, which is ongoing, and symptom which is insidious onset and similar type of to the first episode of jaundice, but it is not resolving still now. There is history of miscarriage after 7 days of onset of second episode of jaundice at around 20 week of gestation, and there is no history of eclampsia or gestational diabetes during the pregnancy. So negative history, there is no history suggestive of cholestasis in form of clay color stool, itching. There is no history of pain, abdomen, fever, nausea, vomiting, prodromal symptoms. There is no history suggestive of hepatic decompensation. There is no history of weight loss, anorexia, altered bowel habit, joints pain, joint swelling, photosensitivity. There is no history of high risk behavior or any complementary alternative medicine or short term or long term over the counter medicine intake. Background history. Patient is diagnosed case of SLE in 2014 based upon the AC American College of Rheumatological criteria. Patient had severe generalized multiple joints pain with joint swelling with nephrotic range of nephrotic range of proteinuria, and patient had photosensitivity malar rash. So patient was started on treatment with methotrexate and steroid, but patient didn't tolerate methotrexate initially and developed severe mucositis. So patient was switched to cyclophosphamide induction dose followed by MMF maintenance. With MMF, patient maintained remission in 2017. While on MMF, patient had miscarriage, which was likely due to the MMF treatment. So patient was switched to the lower dose of methotrexate 10 mg once a week. With this, patient remained remission, and from 2019 patient stopped all the treatment by herself and still maintained the remission. So past history is not significant except the SLE. There is no history of diabetes mellitus, no history of any thromboembolic disease, thyroid disorder, or any intervention in form of endoscopic or surgery. There is no history of jaundice in past. So personal history, patient is vegetarian by diet. Calorie intake is around 2000 to 2200 kilocalorie per day. Protein is intake around 40 gram per day with deficit of 300 kilocalorie per day and protein deficit of 15 gram per day. Patient's eco performance status is 1. Social academic performance is satisfactory. Patients belong to lower middle class as per the modified Kupus-Comi scale. There is no issue of any ill habits or any high risk behavior in this patient. So family history is not significant except mother is diabetic for last 10 years. There is no issue of connective tissue disorder, chronic liver disease, or malignancy or prolonged jaundice in the family. Patient born with non-consecutive marriage. I would like to summarize my case. A 32-year-old female who is a known case of SLE for last 7 years, who stopped treatment for last 3 years, still maintained remission, presented with chief complaint of fatigability for 9 months, with two distinct episodes, non-cholestatic painless jaundice for last 7 months apart. First episode resolved spontaneously, and second episode for last 2.5 months, with resolution of jaundice in between, with history of prodromal symptoms, loss of appetite, with no history of prodromal symptom, loss of appetite or weight loss or any decompensation or complementary alternative medicine. So with background of SLE, I would like to keep my differential diagnosis in form of autoimmune hepatitis, lupus hepatitis, Wilson's disease, viral hepatitis, and lower down the gallstone disease in this patient. So let's discuss the pros and cons related to the differential diagnosis. So patients,
Can you first tell us the syndromic diagnosis in this patient? What is your diagnosis? So there are two episodes of jaundice in the background of SLE. What's your syndromic diagnosis?
Sir, syndromic diagnosis patients having predominantly no history of cholestasis, so predominantly hepatocellular type of jaundice with resolution of symptom in between. So there is no issue of loss of appetite or weight loss. So syndromically, anatomically, is liver is involved. Hepatocellular type of jaundice mainly cause related to infective or inflammatory cause, sir.
So why did you bring gallstone disease if you're saying it's recurrent non-cholestatic painless jaundice?
Sir, there is more.
That doesn't fit into your syndrome.
Yes, sir. This doesn't fit in my syndrome, but sir, I would like to still keep in mind because patient is young, female, fertile, and
No, no.
there is
In that case, you say that your possibility under recurrent non-cholestatic painless jaundice is 1, 2, 3, and 4.
yes, sir.
Fifth is not under that syndrome. So you are changing the syndrome, isn't it? To bring the
Yes, sir.
fifth possibility.
Yes, sir. How I should keep.
What I'm not agreeing is that you cannot put a main heading as recurrent non-cholestatic painless jaundice,
Okay,
and
sir.
then you say that there are five possibilities, and then fifth possibility, I have an objection. Either you say that there is another syndrome which is
Yes, sir.
possible,
Yes, sir.
or you don't keep your fifth possibility.
Yes, sir.
You agree or you don't agree?
Yes, sir. I agree, sir.
All right.
Thank you. So things favoring autoimmune hepatitis is patient is young female having already one autoimmune condition in form of SLE, and fatiguability is predominant symptom in these patients as fatiguability is present in around 85% of patients with autoimmune hepatitis. But it has been shown that with recurrent remitting episode of jaundice, there is usually seen usually there is signs of progression of liver disease in autoimmune hepatitis, which is not seen in these patients. Another differential diagnosis is lupus hepatitis, as patient having underlying SLEs and there is no progression of disease. Lupus hepatitis rarely having a progression of disease or underlying or going to develop CLD. Things go against is lupus nephritis usually occurs with background of active SLE disease, which is with by history, which is not seen in these patients, and it usually doesn't resolve without treatment. So these things going against to lupus nephritis. My third possibility is Wilson's disease, as patient having recurrent jaundice and patient is
Can I
young age.
interrupt you? Can I interrupt
Yes,
you
sir.
here? Now, in
Yes,
your
sir.
first possibility, you have said AIH with
Yes,
SLE. So, how common
yes, sir.
is that association? Either way, how many patients of SLE will have AIH, and how many patients of AIH will have SLE?
Sir, a patient having AIH having 1 to 3% development of SLE in these patients, and patient with SLE AIH is still uncommon. These usually there is a usually case reports. Not a long study has been done, but few studies in outside India says around 2 to 3% of AIH can be seen in SLE patients. Sir.
Um, how sure are you about the diagnosis of SLE in this patient?
Sir, patient has symptoms related to SLE, and serology also was positive and diagnosed according to the ACR criteria, sir.
So, did the patient tell you about the serological reports?
Sir, patient didn't tell, but sir, we found the report, sir.
Hmm. See, when you do a clinical evaluation, the reports may not be available until the
Yes,
patient
sir.
tells the report. So, if you have obtained those reports from the file, then this is not what we are looking at. We are looking at clinical interpretation.
Yes, sir.
So, in clinical interpretation, some patients may be very educated and intelligent, and they can tell you that these are my parameters which are positive. So, here you are going primarily by your clinical history taking. So,
Yes,
by
sir.
clinical history taking, can you be so sure that it is a SLE?
Patient having multiple joint pain, joint swelling. Patient has puffiness of eyes, had photosensitive rash, and patient also saying there is a pink discoloration of cheek. So this suggests malar rash. So clinical symptoms, patients may fit into the SLE, but this has to be confirmed by serological investigation and according to the ACR criteria, sir. So clinically, sir, symptoms were there which suggest SLE, sir.
Okay, carry on.
Okay. Uh,
See,
uh,
I told you why I asked this question, and I would want Dr. Rajiv Mehta and Dr. Mayank to get into this also. That when you have a real exam, and the exam you may get some information from somewhere that this patient is a known case of SLE. Now, please be careful that you don't get that information which has been obtained unofficially into your presentation. Otherwise, you'll be in a soup.
yes, sir.
Okay, sir.
All right.
Yes, yes, sir.
All right. Carry on.
Uh, patient with Wilson disease who present after the 30 years usually having some neurological involvement which is not seen in this patient. So this goes against the Wilson disease. Things supporting viral hepatitis is self short lasting self resolution of hepatitis jaundice, but there was absence of prodromal symptoms. Persistent fatiguity cannot be explained by viral hepatitis, and usually if jaundice are in prolonged course, which is seen in this patient, which is beyond 2.5 months, usually cholestatic symptoms develops, which is not seen in these patients. Gallstone disease, things going more against the gallstone disease than the supporting, but still I would like to keep back of my mind of presence of gallstone disease as patient is young fertile female and there is history of recurrent jaundice. In between the jaundice patient was asymptomatic, but of course there was non-cholestatic symptom and there is no pain or no fever, and persistent fatigue cannot be explained by the gallstone disease. So I would like to go to the examination, sir.
Can we
Uh,
go back to the previous slide?
yes, sir.
Now, you have put Wilson's disease and you have said positive and negative points. Now, I want to know from you how many patients you will get a family history and how many patients will you get neurological involvement.
Sir, patients who presents after the 20 years of age, around 30% of patients having neurological symptoms, and who
70%
present
will
late.
not have neurological. So 70% will not have neurological symptoms.
Yes, sir. After
And
20, and
history?
as the age advances, neurological
No, we are
involvement.
talking of this patient. We are talking of this patient. Let's not
Sir,
get into theory. This is 21 years old female patient, isn't it? If I got it right,
sir, 32 years old female, sir.
32 years old. So,
Yes, sir.
what are the at the age of 32 years? What do you expect? What percentage do you expect neurological involvement?
Sir, according to the data, around 50 to 60% may have neurological symptoms who develop later after the 20 years of age. Uh, according to.
I'm not so sure whether 50 to 60% is the correct figure. Dr. Rajiv,
No, it looks like little higher numbers. It at least 1/4 of the cases have a neurological symptoms.
I think these are the points which, if they are present, they help.
Correct.
Yes, sir.
Absent usually does not help much in diagnosing Wilson's disease. Absence of these symptoms may not be correct. Now, there is some question from somebody as to whether it's a chronic hepatitis B flare.
Uh, sir, this can be, but sir, patient has stopped taking treatment for last 3 years. Usually, reactivation of hepatitis occurs within 6 months to 1.5 years of stopping any immunosuppression drug. So, I haven't kept that possibility in this patient, sir.
No, no, I didn't get it. What has he stopped? 3 years back, I missed that presentation. 3 years
Sir,
back, they stopped. He was taking some antiviral drugs.
no, sir, he was taking methotrexate immunosuppressant, and she stopped taking any immunosuppressant drug. And there is no history suggestive of high risk behavior, and two distinct episodes of relapsing remitting type of hepatitis is literally unusual and in between the 9 months of duration. So still this can be a chronic viral hepatitis B. Uh,
What about drug-induced hepatitis?
Sir, patient is denying any history of drug intake after the 2019. Patient is not taking any complementary alternative medicine, no immunosuppression. There is no history of any NSAID, there is no history of over-the-counter medicine. So that and immunosuppression she also stopped from 2019. So that's why I didn't keep daily here, sir.
So this is a recent patient in this
Yeah,
COVID time.
sir, this is recent patients. We have diagnosed
A
before.
majority of these patients have been taking alternate medicine in the form of Giloy. So have you purposefully asked for that history of Giloy? A lot of
Yes,
these
sir. I
carbonates
asked
which
Giloy or Cardas, she denied she is not taking any medicine which can prevent or which is helpful in preventing COVID disease. No, she's denying any Carda intake or Giloy, sir.
okay, carry on.
So, in examination, in general physical examination, patient is conscious, cooperative, well-oriented, time-place person. Icterus is present. Positive findings are icterus is present. There is presence of hypopigmented patch. In bilateral lower limb, 10 is to 8 centimeter, just above the ankle joint, with loss of hair and which is non-pruritic, which likely suggestive of vitiligo patch. And there is history. There is alopecia, but no alopecia, but easily pluckable hair. These are the positive findings. Other findings are absent in form of there is absence of pallor, absence of sign of chronic liver disease, no clubbing cyanosis, colonychia, pedal edema, thyroid is non-palpable, no rashes or hyperpigmented patch.
Don't take me
Uh,
otherwise, but why should you, in your physical examination, find out easily pluckable hair? Did you pluck the hair and find out whether they're easily pluckable?
Sir,
It's a part of your general physical examination. If you tell me no alopecia, till that part I can agree. But how do you, in clinical examination as a doctor, talk about pluckability of the hair?
sir, just keeping hands over her heads, I could see some of the hairs in my hand. So I didn't plug the hair, but it was easily coming out in the hand, sir. That's
Be
why.
very careful in the terminology which you use in your exam. See, this presentation is not to know your knowledge. This
Yes,
presentation, and Dr. Rajiv, there cannot be a better person than Dr. Rajiv Mehta who is here, that in the exam you should be very, very careful of the terminology which you use. Okay,
yes, sir.
carry on.
Height is 165 centimeter, weight is 53 kg, BMI of 18 kg meter square, BP is 110 by 70 mm, pulse rate is 75, or peripheral pulse are palpable. In systemic examination, uh, uh, abdomen is flat, symmetrical. On inspection, abdomen is flat, symmetrical, no bulge, no distension, no visible mass or vein, or no scar or no redness. On palpation, superficial palpation, abdomen is soft, non-tender, no rigidity. Hepatomegaly is there, which is of one finger span below costal cartilage, which is non-tender, consistency is soft, edge and surface are smooth and regular, and moves with respiration. There is no splenomegaly. On percussions, abdomen is having tympanic node with liver span of 16 centimeters, right mid-clavicular line, and there is no shifting dullness. On auscultation, no brood or vowel sounds are normal heard. On per-rectal examination, there is absence of skin tags, no sinus, fistula, or external swelling, as per-rectal examination is normal. On oral examination is also normal, no oral thrust, no oral ulcers, and joint, spine, and back examination were normal. And rest of the system examination were unremarkable. So this is just to show timeline of these patients. Patient diagnosed to SLE in 2014, had miscarriage on MMF on 2017. Then switched to methotrexate, stopped all medicine from 2019, had a first episode of jaundice in April, May 2021, which resolved in 35 to 40 days, and had a continuous fatigability. Had a conceived in 2000, July 2021, had second episode of jaundice from first week of December, and had miscarriage at 20th week of gestation after 7 days of onset of jaundice. So summarizes of case, sir. After the examination, a 32 years old female, a known case of SLE with history of miscarriage.
So
Two,
your this summary and the DD is the same as you discussed after your presentation, after your
yeah,
clinical history
yes, sir.
taking. So
Yes,
there's
sir.
no change.
Yes, sir.
All right. Dr. Mehta, you have any question? Dr. Mayank?
Yes, Kamlesh, just tell us, as Dr. Goenka sir has pointed out last time, a few minutes back, do you feel from this, isn't a distinct one, or it is correlated with the SLE?
Sir, it can be a distinct one because usually, sir, SLE related hepatitis occurs with underlying active or ongoing active SLE disease. With symptom and examination, I could not find any symptoms regarding the activity of SLE. So it can be altogether distinct episode to the SLE, but still we need to confirm with investigation and other
Okay,
investigation.
okay.
So, sir, going to the investigation part, sir. In April, first episode of jaundice, had patient had bilirubin of 69 with predominant of direct bilirubin with SGOT, higher SGOT, SGPT more than 10 times, with normal ALP, GGT, and with rest of the LFT were normal, and renal function test was normal, suggesting a hepatocellular type of jaundice. with mild anemia, with no thrombocytopenia, no leukopenia. Patient had jaundice from first week of December 2021, which is the second episode of jaundice, which shows progressive increase in jaundice with some resolution in jaundice afterward. With SGOT and SGPT are raised, suggestive of hepatocellular type of jaundice, with mildly elevated ALP in between, but then after ALP and GGT are normal. And if we saw albumin globulin levels, recently globulins suggestive are quite high than the albumin, and AG reversal is there. And with mild anemia and no thrombocytopenia, with in between patient has higher INR, which resolve without any treatment, sir. So this predominantly suggests to hepatocellular type of jaundice with higher globulin level. Uh, Further investigation show all the viral markers were negative. With for autoimmune parameters, we assess ANA, which was 1:80. Asthma was also positive. Anti-alchem AMA were negative. Serum IgG level were high. Normal range was 1,600 milligram per deciliter, and in this patient was 2,100. Complement levels were normal. Cellular plasmin was normal.
So,
For any, sir.
so
Yes, sir.
obviously your diagnosis is going towards autoimmune hepatitis, isn't it?
Yes, sir.
So what tests will differentiate whether it is lupus hepatitis or autoimmune hepatitis?
Sir, usually histology is required to differentiate in between, but still sometime with histology it is difficult to differentiate between AIH SLE overlap or lupus hepatitis. So some of the serology are also there in form anti-ribosable P antibody, which is commonly seen in the patient with SLE, not seen in autoimmune hepatitis, and asthma is not seen in SLE patients, seen in AIH, and complement with active SLE disease, complementary levels are usually low. So these things, and with urine examination, we can see if patient having active proteinuria, which suggests active SLE. With so active SLE supports the lupus hepatitis, and inactive SLE supports other etiologies. In urine examination, pus cells were 2 to 3, albumin was +1. In 24-hour urine protein was 100 milligram in 24 hours, which is not significant. No CAST, no RBC in these patients, sir.
So was a biopsy done?
Yes, sir. Next, USG was unremarkable. MRCP was done outside, which was normal. So liver biopsy was done, which showed 14 to 15 portal tracts, which suggests to adequacy of liver biopsy. Architects was preserved. There was predominant lymphoplasmatic infiltration with interface hepatitis. This formation of hepatocyte rosette formation and imperipolysis were also seen. There was focal hepatocyte necrosis were also seen. There was no steatosis, no ductopenia, no bile duct injury. Mesenteric stain for fibrosis were negative, and iron stains were negative. I have seen shown slides of liver histology, which shows tangentially cut portal vein. Here we can see this is a portal vein. This is a hepatic artery, which you can see some muscular component in this, and there is a callus bile duct, and we can see lots of lymphocytic infiltration, inflammatory cells, and which we can see in inflammation, which we cannot distinct the limiting plate, but it shows the inflammation is going from portal tracts to surrounding hepatocytes, suggestive of disruption of limiting plate, suggestive of interface hepatitis. This is a high resolution slide of this previous slide, suggestive of lymphoplasmatic infiltration with numerous plasma cell. Here we can see the plasma cell. Another we over can see over here. Another over can see plasma cell, which has a eccentric nucleus with pinkish cytoplasm. In high resolution, we can even see uh, which can be seen, and there are some hepatocyte necrosis which can we can appreciate over here. Another slide, we can see hepatic rosette formation, which can be seen in autoimmune hepatitis. And here we can see hepatocyte necrosis, and here we can see empyropolysis, that hepatocytes have engulfed the lymphocytes here, and some of the here we can see empyropolysis, and there is a mild cholestasis can be seen over here, which can be seen in acute severe autoimmune hepatitis. So histology is suggestive of autoimmune hepatitis. In lupus hepatitis, there is a predominant of lobular inflammation and lobular infiltration and positive of plasma cell. So in from a biopsy, we can so suggest that it can be autoimmune hepatitis. So let's apply the simplified scoring system. Our patient has ANA 1 is to 80, 2 points. Serum IgG level is more than 1.1 times, which has 2 points. Histological is typical, 2 point, and viral markers are negative. So, according to simplified scoring system, this diagnosis fits into the autoimmune hepatitis with background of SLE. So, final diagnosis was made in form of autoimmune hepatitis with background of SLE and patient having vitiligo. So, treatment was started in form of steroid. After the treatment was started, we can
Yes.
see there is a resolution of jaundice, and
Dr.
there is some.
Kamlesh,
Yes, sir.
uh, sorry to interrupt you. Just
Okay.
that same slide, yes. Here you have shown that the patient has raised transaminases and SGOT is SGP is higher than SGPT.
Yes, sir.
Can you explain that? Or in which conditions do you see that SGOT is higher than SGPT?
Sir, a common condition in which SGOT is more than SGPT is alcoholic hepatitis or severe underlying severe fibrosis. Then a drug-induced liver injury in which predominantly SGOT is on higher side, which then few of the causes like in Reyes syndrome, which is seen in children, not in here, having predominant of raised in SGOT than the SGPT. Sir.
So here you have higher SGOT than SGPT. Can you
Yes, sir.
explain that?
Sir, from it is difficult to explain over here because in autoimmune hepatitis there is a predominant of SGPT more than SGOT. But usually we here we can see SGPT was higher initially. This may be due to SGPT having lower T half life. So and SGOT has a higher half life. So this may be the reason, but it is difficult to explain uh, in these patients why SGOT was more than SGPT.
If there is associated hemolysis, can this happen?
Yes, sir. This can happen even in hemolysis or yes, sir. This can happen. Uh, but sir,
Okay.
bilirubin is predominantly of direct. So it, in hemolysis or in rhabdomyolysis also SGOT can raise, but I am not. I mean, it's difficult to consider over here.
Sure. Okay.
That's what mainly we have to see whether this is an extrahepatic cause of SGOT. That was a question asked from the people. So basically, that's sometimes very difficult to identify. In given situation, probably the reason would be activity of the disease. Maybe there is a reason where higher activity of the disease of autoimmune hepatitis.
Yes, sir. Yes, sir. And SGOT mainly raises when there is a mitochondrial damage. So this can suggest there is a severe disease in form causing mitochondrial damage.
Sure. So how did you treated this patient and
Sir,
what was
sir, according to ASLD guideline, we started prednisolone 40 mg per day, and after 15 days, there was improvement in bilirubin, improvement in transaminitis, and after 15 days, we added azathioprine, initially 50 mg. Then, with subsequent, we will monitor the LFT in 2 to 4 weeks and treat according. Then we need to reduce the dose of steroid up to 10 mg per day in after 4 weeks. And then, if patient maintains the remission, then steroid can be tapered off, and azathioprine dose can be escalated to 2 mg per kg according to the improvement or according to the response, and then steroid can be tapered out over 6 months in case
right, right. Dr. Kamlesh, can you just summarize the literature because we are short of time now. We are just 6:35. You have only 3 minutes to summarize the
okay,
literature.
So SLE can have commonly have deranged LFT. Uh, Liver test abnormalities can be seen in 60% of patients. Most common causes are DILI, followed by viral hepatitis, NAFLD, or vascular complication. AIH is uncommon, means can be seen in up to 1 to 3% of patients according to literature. And lupus nephritis can affect up to 3 to 8% of SLE patients, but it usually seen with underlying active SLE, which can be differentiated from SLEDI 2K scoring system, score more than 4 suggestive of active disease. Which and AIH in SLE is a rare combination. It is considered to be distinct disease, which can be associated just like other autoimmune disease. And differentiation is sometimes very much difficult. Histology is essential. This is just a list of the causes in which LFT derangement can be seen in SLE patients. And this is just to differentiate points between the lupus nephritis and autoimmune hepatitis. In lupus nephritis, having mild to moderate disease, AIH have a can be asymptomatic to can have a ALF or ACLF. ACR criteria can diagnose lupus. ANA is commonly seen in lupus but can't be seen in AIH. Differentiating point, important differentiating point is presence of asthma, anti-ribosomal P antibody, presence of ALKM1 or SL, other auto antibody suggestive of autoimmune hepatitis, and complementary level usually low in lupus nephritis. And histology lupus nephritis suggests to predominant of lobular inflammation, and AIH predominant to interface hepatitis. Response to steroids are almost similar in these patients.
Kamlesh, there was a question: is it a polyglandular autoimmune disease?
Glandular autoimmune. Sir, other means other involvement, other organ involvement or other glandular involvement means was not seen. Sir, sorry. No absolute answer, sir. It's difficult to say, but
Right. So, anything else you want to tell Dr. Kamlesh?
sir, that's all from my side.
Right. So, this is a disease which is autoimmune hepatitis with coexisting SLE, and SLE is under remission, and patient did well with standard of care. Right.
Yes, sir. Yes, sir.
Thank you so much, Dr. Kamlesh.
Yes, sir. Thank you, sir.
Now, Dr. Raj Tande, who is a second year DNB student from Surat Institute of Digestive Science, is presenting a very good article. Over to you, Raj.
Good evening, respected teachers and colleagues. My name is Dr. Raj, and I am a DNB trainee at SIDS Hospital at Surat. We'll be discussing on reactivation of hepatitis B on patients on immunosuppressive therapy. So, by definition, the HBV reactivation or reactivation of hepatitis B is defined as the loss of immune response in patients who are either HBsAg positive and HBC antibody positive, or just the antibody core antibody is positive and HBsAg negative, who are undergoing immunosuppressive therapy for a concomitant medical condition. So the basic criteria for HBV reactivation is if the patient is positive for both HBsAg and core antibodies, there should be at least a 2 log increase, that is almost 100 time increase in the HBV DNA levels from the baseline levels. If the HBV was undetectable at the baseline, there should be a level HBV DNA level of more than 100 international units per ml if it was previously undetectable at the baseline. For patients who is positive for the core antibody and negative for the HBsAg, there are two criteria. Either there should be a reverse seroconversion, that is in patients who was previously HBsAg negative turns out to be HBsAg positive, or if the HBV DNA which was previously undetectable becomes detectable. So this is the basic criteria and definitions for reactivation of the hepatitis B. we need to keep in mind that the ALT levels do not come into picture here. The previous means the latest ASLD and the EASL guidelines. Even the ASLD says that in patients who are positive for the HBs AG and core antibody, if there is a known baseline of the HBV DNA and which was previously detectable, there should be at least 100-fold increase, that is 2 log increase, which is in accordance with this latest guidelines published in the Hepatology International. And if there was patient had previously undetectable HPV DNA levels, the HPV DNA should be at least more than 1,000 international units per ml. If the patient had, we have no idea about the DNA baseline, the DNA baseline, the HPV DNA should be at least more than 10,000 international units per ml. In patients who is negative for HBsAg, that is surface antigen, and positive for the core antibody, uh, again, the similar, that is, there is should be a presence of reverse seroconversion, that is from HBsAg negative to the positive, or there should be development of detectable DNA in which it was previously undetectable. The result doesn't specify specific guidelines, criteria, or definitions for the HBV reactivation. So coming to the pathophysiology in brief, the main important point here to stress is the closed circular covalent DNA. It is the presence of the CCC DNA that is responsible for the majority of the HBV reactivation. During the life cycle of the HBV, the virions enter via the sodium taurocholate receptors in the cells. Within the cytoplasm, the double-stranded DNA enters the nucleus, where with the help of the viral polymerase, it gets converted into the closed circular DNA. The closed circular DNA serves as a template for the viral mRNA, which is held by the RNA polymerase over here. The mRNA as such is a template for the further the mRNA RNA polymerase acts, and there is the presence of development of the whole viral RNA genome consisting of the surface polymerase X proteins of the HBV, and that is followed by the reverse transcriptase to again form this double-stranded HBV viron particle. And from here we can have two ways. Either it can enter the endoplasmic reticulum and followed by the viral release, or it can reinforce the closed circular DNA. And that is when, because at present we have no therapies that actually target the CCC DNA right now. So in any patient with even with previous infection with HBsAg negative and anti-core antibody positive, there is a chance of reactivation. So we need to remember that the closed circular covalent DNA is the most important part in the HBV reactivation. So talking about the spectrum, there can be three manifestations of HBV reactivation. There can be silent reactivation where the patient usually is asymptomatic with elevated HBV DNA levels without the presence of overt hepatitis. That is, there is no SGPT elevation. As HBV associated hepatitis, that is, along with the elevated viral load, there will be raised transaminases as well as histological evidence of hepatitis. Rarely, but also patient may present with fulminant hepatic failure. That is elevated viral load along with hepatic synthetic defects, mainly encephalopathy and coagulopathy. Now, there are various risk factors for reactivation of hepatitis B. As usual, there are host, virological, and the immunosuppression regimen that the patient is undergoing. Talking about the host factors, male patients age more than 50 and presence of cirrhosis or a hepatological malignancy is a risk factor for the reactivation. Of the virological factors are higher HBV DNA, presence of HBsAg and HBe antigen and envelope antigen positive, absence of the antibody to the surface antigen, and co-infection with either hepatitis C, hepatitis D, or HIV is a risk factor. Uh, Talking about the immunosuppressive regimen, it can be divided into high risk, moderate risk, and a low risk, which we'll be discussing in the coming slide. This high risk denotes increased chance of reactivation. For patient who is HBsAg positive, The high-risk drugs or immunosuppressive regimens include anti-CD20 or beta cell depleting antibodies, mainly rituximab. If the steroids are used for more than 20 mg per day for a period of more than 4 weeks, stronger anti-TNF agents like infliximab, adalimumab, golimumab, and certolizumab, anthracyclines in the chemotherapies, any patients undergoing hematopoietic stem cell transplantation, and patient who is under directly acting antivirals for HCV co-infection, except that is the patients who are non-cirrhotics and with the quantitative HbA1c levels less than 10 international units per ml have do not have a high risk. For patients who are core antibody positive with negative surface antigen, again the first two, that is the anti-CD20 antibodies, that is beta cell depleting agents, are possess a high risk, along with allogenic means along with patient undergoing stem cell transplantation. Uh, Cytotoxic chemotherapies except the anthracyclines uh, and anti-TNF agents like etanercept and steroid use of 10 to 20, that is less than 20 mg per day for more than 40 weeks, possess a moderate risk, that is 1 to 10% chances of reactivation. And in patients who is core antibody positive but surface antigen negative, the immunosuppressive therapies which were high risk for the HBsAg positive patient pose only a moderate risk for patients who are just core antibody positive. This gives us a rough idea that patients who are HBsAg positive are more likely to undergo hepatitis B reactivation as compared to patients who are just core antibody positive and negative surface antigen. Conventional immunosuppressants like methotrexate, azathioprines, or steroids, if used less than 10 milligrams per day, have a low risk. Uh, Now, coming to reactivation in the cancer chemotherapy, uh, this is just a flow diagram or flow chart which can guide us regarding patient presenting with who is undergoing chemotherapy. So any patient who is undergoing chemotherapy or is planned for a stem cell transplant for a hematologic or non-hematologic malignancy, he should be screened for these two parameters, that is surface antigen and core antigen, antibodies to the core antigen. If the surface antigen is positive, we should check the liver status, that is in accordance with the ASLD and EASL guidelines. If the patient satisfies, that is the HBV DNA is elevated more than 2000 and ELT is more than 1 or 2 times, HBV therapy or treatment is recommended. Suppose if the patient is not does not fit into the HBV treatment guideline, still it is recommended that the patient undergoes chemotherapy or preemptive chemotherapy. Preemptive chemotherapy is basically it should be started before the initiation of the chemotherapy for the underlying disease, and should be continued until 12 to 18 months post chemotherapy. And during the time, the HBV and the HBV DNA level and SGPT level should be monitored regularly, almost at least between 3 to 6 months. Now, patients who are negative for the surface antigen but positive for the core antibody, the first step to do is check the HBV DNA level. If it is negative, we can proceed for the chemotherapy while monitoring for the HBsAg and the HBV DNA levels every 3 to 6 months until there is stoppage of the chemotherapy. In patients who are HBV DNA positive, and we should always means we should give the chemotherapy or we should give the antivirals, nucleotide or nucleoside analogs. And also in patient with high risk, that is just we discussed, that patient having undergoing B cell depleting agents or hematopoietic stem cell transplant, they should also have antivirals. Suppose if both the antibody to the core antigen and the surface antigen is negative, patient should be vaccinated, and it should be done using an accelerated schedule, that is at 0, 1, and 2 months. And it should be rechecked after 1 to 2 months post the last scheduled dose of the vaccine, and should be revaccinated if the anti-HBs titers is less than 10 international units per ml. This is regarding the cancer chemotherapy. Now, regarding biologicals for non-malignant diseases, Biologicals we usually in gastroenterology we use mainly for autoimmune diseases, mostly inflammatory bowel disease and autoimmune hepatitis. So here again, the risk of hepatitis B reactivation is much more in patients who are hepatitis HBsAg positive rather than the occult HBV infection. As discussed, rituximab and potent anti-TNF antibodies, that is the infliximabs, adalimumab, certolizumab, carry a higher risk. Etanercept and abatacept carry a moderate risk. Patient should be tested for HBsAg and anti-HBC. In HBsAg positive patient, we should be evaluating if the patient has just a chronic HBV infection or a chronic hepatitis or a cirrhosis, because that will decide the further line of treatment. In patients with chronic HBV infection, we can just monitor and check the HBV DNA levels uh, 3 to 6 monthly, and start the treatment if there is presence of overt hepatitis, that is elevation in the SGPT. Patients with chronic hepatitis or cirrhosis should be started on antivirals. Now, regarding the patients who are HBsAg positive inactive carriers, still there is data almost says that there is 20 to 30% of chances of reactivation by 20 to 30% chances of reactivation, and nucleotide analogs should be given. The preferable are entecavir or tenofovir disoproxil or alafenamide. In patients who are HBsAg negative, their surface antigen negative, but antibody to the core antigen is positive. Again, the previously discussed HBV DNA should be done and treated accordingly. Now, regarding the negative HBV serology, as discussed, vaccination should be done at double dose at 0, 1, and 2 months. Serological response should be checked. The regular monitoring of HBs anti-HBs titer should be performed every 2 years, and booster dose is recommended if the titer falls below 100 million international units per ml. This is just another pictorial representation of just what we just discussed. Patients with HBsAg positive invariably will need antivirals. If there is core antibody positive with negative surface antigen, we should check for the HBV DNA. And if there is both are negative, we should go for vaccination. Now, the what the international bodies, that is the ASLD and EASL, says, they recommend HBS in patients with hepatitis HBsAg positive. They recommend starting of the antivirals as prophylaxis for all patients, regardless of the type of the immunosuppressive therapy or the HBV DNA levels or the SGPT levels. In patients who are positive for antibody to the core antigen and negative for HBsAg, the ASLD suggests that only drugs that target the B lymphocytes should be given prophylaxis, that is rituximab, or patients undergoing stem cell transplant therapy. Patients who are undergoing or having biologicals for rheumatological IBD or psoriasis or any dermatological condition can be monitored without any anti-HBV prophylaxis. Uh, as as we discussed in the previous slide, that biologicals in patients who are positive for the core antibody and negative for the surface antigen have only moderate risk. As far as the EASL, they recommend testing for the HBV DNA before the starting the immunosuppression if the patient is HBsAg positive, and a cutoff value of 100 international units per ml, the patient should go for prophylaxis. Again, high risk, that is the beta cell depleting agents or stem cell transplant or anthracycline chemotherapy. Again, prophylaxis is indicated. In moderate and low risk patients, monitoring can be done for HBsAg and HBV DNA, that is for reactivation, every 1 to 3 months, and patient can be given preemptive therapy. Preemptive therapy basically means that we should monitor on the ongoing chemotherapy or on the ongoing biologicals, and if there is reverse seroconversion, that is positive HBsAg from negative, or the increase in the HBV DNA levels or the detection of HBV DNA levels in previously undetectable, we should give the therapy. That is what preemptive therapy means. So once we start this prophylaxis, how long should it be given? That is the question. So the recent article in Journal of Clinical Gastroenterology, the immunosuppressants except beta cell depleting agents or stem cell transplant patients, it can be safely continued to 6 to 12 months. and duration of the HBV prophylaxis, that is. And after stopping prophylaxis, the patient should be monitored for HBsAg and HBV DNA levels until 12 months, after which monitoring can be stopped. Uh, there are chances of reactivation even after 12 months, but the cost benefit ratio doesn't let us guide or doesn't give us the recommendation that it should be continued beyond 12 months. As far as the beta cell depleting agents or stem cell transplant are concerned, the duration of HB prophylaxis is slightly higher, that is slightly more, that is 12 to 18 months. And after stopping HBV or after stopping the antiviral prophylaxis, the HBV DNA and the HBsAg should be monitored for at least 12 to 24 months. Coming to the patients for HBV reactivation in patient undergoing solid transplant, mainly we are concerned about liver transplant patients. We'll also discuss about non-liver solid organ transplant. So the goal is to achieve clinical stabilization and avoid liver transplant if possible. Now, the reason for this is in patients with decompensated cirrhosis, the 5-year survival rate is extremely low, that is just 14%. And that is why we have ample of data to suggest that the nucleotide analogs or nucleoside analogs have a role in modifying the natural history of patients with decompensated cirrhosis. It has been seen that almost 35% of the patient can be delisted from the liver transplant list. There has been seen in the improvement of the child score of more than 12 in more than 40 to 50 patients. HBV DNA levels have been seen to be undetected in more than 80 patients post 1 year of therapy, and that also lowers the risk of HCC development. And that is the reason why a patient on transplant awaiting list for hepatitis B positive, mostly patient with decompensated cirrhosis, should be started on antivirals if the HBV DNA is detectable, even detectable, irrespective of the levels or the SGPT levels. Now, precautions in patients on the antivirals, renal adjustment is required for anticavir and tenofovir disproxil. The dose is usually the it should be given at 48 hours in patients with creatinine clearance less than 50 ml per minute. If it is even less than that, as is 15 to 30, it should be given at 72 hours. Or if it is more than 50 ml per minute, the usual doses can be given. Another risk is the presence of lactic acidosis, which is usually seen in patients with impaired renal function or MELD score of more than 22. Post liver transplant, the HBV reactivation has been defined as the reappearance of the circulating surface antigen, that is HBsAg positive, irrespective of the presence of the detectable DNA level after the liver transplant. So the how to go about it is in patients who are post transplant, the antiviral should be that antiviral which had been started pre-transplant should be continued in the post-transplant phase 2. The risk factors for HBV reactivation include higher HBV DNA level at the time of liver transplant, HBeAg positive, presence of hepatocellular carcinoma, and antiviral drug resistance. Also, patients who are presenting as fulminant liver failure or acute liver failure have a lower risk of recurrence because the immune-mediated damage. We know that HBV is not a cytopathic virus. That is, the immune-mediated damage done by the CD8 cells is responsible for the acute liver failure in patients with hepatitis B. So, because of the immune-mediated damage, low pre-liver transplant HBV DNA levels, the chances of recurrence are much more less in patients presenting with acute liver failure in hepatitis B.
Raj, can you wind up fast? There is very little
Yes.
time left now.
Yes. Yes. Uh, Regarding the management, early studies have shown that hepatitis B immunoglobulin should be mandatory, but now the recent studies have concluded that HBV immunoglobulin is not required in each and every scenario. Now, with the advent of the antivirals with high barrier to genetic resistance like tenofovir and entecavir, uh, HBV immunoglobulin is not required in patients who are low risk. This is just a flow chart, a flow diagram regarding guiding the treatment. In patients who are undergoing liver transplant at the post-transplant level, if the Patient had undetectable level at the time, and undetectable HBV DNA at the time of liver transplant confers a low risk to this patient, and they can be safely given nucleotide analogs, that is the lifelong therapy. In patients who have DNA detectable at the time of liver transplant or co-infection with HIV, HDV, or hepatocellular carcinoma, they confer a high risk, and these patients should be given. That is, there is no data at present to deny the use of HBV IG in patients with high risk patients, in patients with high risk for reactivation, and these patients should be given hepatitis B immune globulin in the anhepatic phase, followed by 10,000 units in the anhepatic phase, followed by 6,000 to 1,000 units daily intramuscularly for 7 days, and then weekly for the next 3 weeks, 3 weeks, and then monthly for the rest of the 1 year. The aim is to keep the anti-HBs level more than 100 international units per ml. Again, the immune globulin can be stopped because we can check the HBV DNA and HBs AG monthly. And once both of these become negative, we can safely stop immunoglobulins. Suppose if a patient has received a liver graft from anti-core antibody positive patient, and the recipient, we have to see the status of the recipient, that is the HBV status and the antibody status. Just in the patients, all of these patients will require nucleotide analogs. Just in the patients who are positive for the antibody for the surface antigen as well as the antibody for the core antigen will require no prophylaxis. In patients who are HBsAg positive and high DNA titers, they will require immunoglobulin plus nucleotide analogs, whereas in the patients with low HBV titers and HBe antigen negative, there is an envelope negative, will require only nucleotide analogs. Uh, Talking about non-liver transplant, it has this similar in patients as compared to liver transplant. Only one difference is in patients who are core antibody positive and anti-H in patients who are core antibody positive and HBsAg negative, either monitoring or 6 to 12 months of intensified immunosuppression therapy can be given. This is in contrast with the liver transplant, where the chances of HBV reoccurrence in this scenario is much more higher. Rest everything is almost similar. Uh, for steroids, the reason for reactivation is mostly the glucocorticoid responsive element, which is a transcription regulator, and this transcription regulator is upregulated by the steroids. Another reason is steroids suppress the cell-mediated immunity, and which is important because the interleukins that are important for the B and T cell proliferation, because B cell is responsible for the antibody response, and T cell proliferation is responsible for the clearance of the HPV. So the current recommendation is to start antivirals in patients who are going to have steroids for more than 4 weeks at a dose of more than 20 mg. In those patients, if any of the HBsAg or antibody and anti-HBC is positive, the antiviral should be started. A lesser dose or duration of the oral corticosteroid, just screening is recommended, and antiviral or antiviral therapy is not recommended. Same for local inhalational intraocular corticosteroids. Only pre-therapy screening is, even pre-therapy screening is not recommended. In patients with chronic kidney disease, if the patient is negative for HBsAg, vaccination is advised. On hemodialysis or not on hemodialysis, the patients are required to take vaccines. On hemodialysis, there is double dose of vaccine or at 0, 1, 2, and 6 months. Or not on hemodialysis, the 3 doses of vaccine are at standard doses is enough. The goal is to maintain HBs of more than 10 international units per ml. So to conclude my slide, patients on immunosuppression, if the patient is HBsAg positive and there is their HBV DNA more than 2,000, treat as chronic hepatitis B. In patients who have levels less than 2,000, if there is a low risk based on the previous slide, we can monitor. But in case of moderate to high risk, we need to give HBV prophylaxis. In patients who are negative for the surface antigen, positive for the core antibody, in low risk patients, again we can monitor. In moderate risk, we can check the HPV DNA levels and treat accordingly. But in the high risk patient, that is rituximab or stem cell therapy, we should give prophylaxis. And when both all the three parameters are negative, we should proceed for HPV vaccination. Thank you, sir.
Thank you very much, Dr. Raj.
Yes, sir.
So, see, India is being an intermediate endemic country for hepatitis B. It's always been advised to check an hepatitis B surface antigen before
Right,
we
sir.
proceed. Right.
Right, sir.
So, Raj, what would be the prevalence of HBsAg positivity in India?
Sir, it is almost 5 to 10% at according to the current literature, and the presence of core antibody is even higher than that, amounting to 15 to 20%, sir.
Right.
So, so probably if I think now it is almost 7 past 3. So if any question from the viewers, all students, anything? You can put it in your chat box to us. No.
There are a few questions in Q&A and chat box both.
Sir, I am not able to see it, sir. Sir, I am not able to see. See, one is
Something has
dose, sir, one is does high dose of intra-articular steroid in HBsAg positive patient without altered LFT is a high risk category? Dr. Raj?
No, sir, it is not a high risk category, sir.
So it's not a high risk
No,
category.
sir. No, sir.
Correct. One question, HB negative recipient received a surface antigen positive donor as a mother in renal transplant. How to approach? See, this is a very interesting question. So the recipient is negative and donor is positive and mother.
Yes.
So this specific is mother. How
Yes,
do
sir.
you treat or how do you approach?
Sir, in the naive patients with, if the recipient is naive for the hepatitis B, we recommend starting the antivirals or the nucleotide or nucleoside analogs prior to the transplant, and continue the antivirals and the the nucleotide analogs post transplant for at least 1 to 2 years. That is, there is no specific time limit given. But post transplant, we can monitor for HBsAg and HBV DNA every 3 to 6 weeks for the presence or the level of the HBV hepatitis B activity, sir. Because
Correct.
there are chances that the recipient will become hepatitis B positive in this scenario, sir.
So the important thing is that the donor HBV DNA envelope antigen status is
Yes, sir.
also very important also for further outcome.
Right, sir.
So basically we have a very safe drugs in the form of TAF and TDF available. So there should not be any problem using it when you are really worried about the reactivation.
Right, sir. It's very high by rate to the resistance, sir.
So, sir, if anything else,